So let's get started. Hi, good evening. Welcome back to the week 7 of problem solving session in medicinal chemistry. I'm Gitanjali Singh, a PMRF fellow from Department of Chemistry at IIT Kanpur. I'll again reiterate a few things. This is the problem solving session that happens every Monday from 6 p.m. to 8 p.m. This is live recorded on Gmeet, and you all have the link for this. You can join every time you want for the problem solving session. Today we'll discuss this week's summary, last week's assignment, and some modular question based on the upcoming assignment. That is, I'll help you solve some of the questions from your week 8 assignment. In case of network disruption, please wait for a few minutes. Do not leave the session. Uh, if it's from my end, I'll join back again with the same link and we'll continue where we last left. You can post your questions during this live session. I'll keep on checking the box. Let me see if there is anything. So I'll keep on checking the chat box during these sessions. If you have any questions, put your question in the chat box. If not, unmute yourself. You can unmute yourself and ask the question then and there. I'll try to solve your doubt as soon as possible. This presentation and class is recorded. The link of the presentation, will be shared to you, and the link of the class will also be shared soon after the class ends. In week 7, Sir discussed drug administration routes, part 1 and part 2, finding lead, part 1 and part 2, drug screening, and a tutorial for drug administration and finding a lead. In my last class, we discussed in details the different routes of drug administration. We'll have a brief recapitulation of the same thing today as well. So, I'll start. So, medicines are actually available in different forms, solid, liquid, suspensions, some in form of ointments or injections, some implants for sustained delivery. There are various kinds of medicine and different formulations. So when we discuss about route of drug administration, there are mainly three types: enteral, parenteral, and local application. Now these are classified on basis of the effect they have. So yes, is there any question? So we'll discuss what kind of effect I'm talking about. So one is systemic effect and the other one is local effect. Systemic effect is the effect produced by a drug after being effectively absorbed in bloodstream. So once the drug is absorbed, the kind of effect it has on the body is called systemic effect. Local effect is the effect produced by a drug in a localized area where it is applied or administered. So in case of ointment, topical application, you can see the effect of the drug then and there. So if there is a cut or anything, what you do is apply your ointment and some kind of infection or anything, and you can see, that kind of local application. Local effect. For systemic effect, the drug, the possible routes for drug entry in the body may be divided into two main classes. That's where enteral and parenteral effects come. For local effects, the drug may be applied externally. It's called local application. So now let's discuss enteral. Enteral comes from the word enteron, in which enteron, that means basically the gut. So in this case, drug is directly placed into gastrointestinal tract. Now it is divided into three further categories: oral, sublingual, and enema. So in case of oral administration, drug is taken directly from mouth and swallowed. So it has the advantage that you don't need any special kind of skill to administer the drug. It's very easy and, most preferred way of having a drug administered. There is no need for sterilization, no specialized skill. But there's a disadvantage. It cannot be given to an unwilling, unconscious person, and difficult patients you know who are not ready to take the drugs, unwilling patients. So that's one thing in case of administration. And there are certain drugs like insulin that undergoes degradation in GIT, and testosterone is destroyed, in all this process as well. There is a term called first pass metabolism. We'll discuss this in later slides. So there are certain disadvantages associated with oral drug administration. Now, sublingual. Sublingual is the drug administration where the drug is, or the medicine is directly, um, administered via cheeks, or in between our trunk. So the drug is kept just under our tongue, and it's very active. It's directly absorbed to the systemic, um, I don't know how to say, yeah. It also escapes the first pass metabolism. It's actively absorbed into the systemic circulation, like ephedrine hydrochloride tablet. It's administered for asthmatic patient to get immediately relief. And in case of enema, the drug is I'm sorry the drug is administered through rectum, through anus, and that's done before, like, if you have to take x-ray or colonoscopy before some surgeries. And yeah, so that's enema. That these all come under enteral. Now, parenteral administration, it can be done via injections or via inhalation. Now, you can see injections. There are several types of injection: intradermal, subcutaneous, intramuscular, intravenous, intraarterial, intrathecal, intramedullary, intraarticular, various kinds. uh, I discussed all of them in my last class, so if you're curious about it, you can just go and see the last lecture. If not, if the question comes, we can discuss it again. Inhalation is when you directly um, inhale a drug via your nose, like, nasal spray or something like that. That is inhalation. So yes, here, in case of oral or rectal administration, the drug first goes to the gut, that is GIT. From there, it can go to portal, to liver via portal system, where the liver first metabolizes it, and it goes, it goes to the bile, and then again to gut. That liver, whatever is left over, passes through liver and goes to kidney, and the kidney excretes it, eliminates it in form of urine. Now, after bypassing this, even after going passing from liver to kidney, some of the drug goes to the plasma, and from plasma it can be eliminated via various other routes, that is from placenta, and it can be transferred from placenta to fetus, and the fetus waste materials are again transferred via a fetus to placenta, placenta to plasma, and from plasma to kidney, and kidney to urine. And just a minute. So this is for oral or rectal administration. Precutaneous, like, that is like when the thing is injected to the subcutaneous layer, like, or precutaneous, like in the skin. From skin, it can go to plasma, and from plasma to, either breast or its area of target. And this is basically how uh, you know, the drug circulates throughout the body In case of intravenous administration, it directly goes to the plasma, and from plasma to various other parts like from kidney, liver, in its site of action everywhere. From in case of intramuscular, you can see it goes to muscle and then plasma, from plasma to liver, most of the time directly to kidney and different other parts. In case of spinal fluid, again intrathecal, it's directly injected to the cerebral fluid, like the brain. It goes to brain and then the plasma and keeps on circulating unless it reaches its target. Inhalation, as we discussed, is directly taken via your nose. It goes to the lungs, the plasma, and then different targets. So when we are discussing about absorption and distribution, we have to discuss about the formulation as well. So this is a very uh, brief slide. So if the formulation is in solid form, there are various other ways. So once you take the medicine in solid form, it disintegrates into granules. Now the dissolution can happen in different forms. It either disintegrates into smaller granules, and that the small granules then further uh, deaggregates into finer particles. Now this finer particles can dissolve into solution, or else if these are easily dissolvable um, you know, capsules or tablets, if they dissolve easily, instead of disintegrating into granules, it will directly dissolve and form solution. Sometimes after the first disintegration, the granules directly form solutions, or else it goes through the same path. Once it becomes solution, um, it can either form micelle, like, you know, fat soluble micelle. You have read this, you might have read this concept in solution phase, or, you know, surface interaction. I'm not going to details into details for this micelles, but it is more or less to make it more lipophilic. And now the drug is in solution in the luminal fluid. Once it crosses that, it can be ionized or unionized. It's easier for unionized drug to travel through you know, the cell membrane. So yeah, the drug will transfer from the unstirred water layer to enterocyte in unbound you know, form, that is ionized and unionized form. Unionized form is always preferred, and ionized form, it's difficult for it to pass through the lipid or bilayer. So you know, we'll discuss this about absorption. So, you know, why is absorption important? Let's discuss this briefly. I think you know, just a slide. This slide is not very good. I'll see if I have a better one. Yeah. So after administration, like we discussed in last class and, you know, in previous slides, there are different routes of administration and everything happen. Now, what is drug absorption? Once the drug is in our body and it has been after administration, the the movement of drug from its site of administration into the bloodstream, making it available for various body parts, you know, various body organs and tissue, making it available for different tissue and organs. It's called drug absorption. The drug has to navigate through different pathway or absorption to reach their targets. There's various factors that influence the drug absorption, like physiochemical properties of the drug, route of administration, gastrointestinal factors, formulation of the drug, and blood flow. Now let's discuss what is this you know, physiochemical properties of the drug that I'm talking about. There are the physiochemical properties of the drug determine how the drug move around the body, starting with lipid solubility. Now, lipid solubility, as I said, is very important for a drug to be absorbed. So it is important in determining how a drug can pass through membranes unless given in intraventricularly, like when it's injected directly into your venous, like ventriculars. So that's called intravenous, and that is like 100% absorbed. So unless apart from that, the lipid solubility of the drug is important, because the drug has to pass through lipid membrane. As you know, that cell is most of the cells are primarily composed of lipid bilayer. Now, this lipid bilayer has a polar head and non-polar tail. Now, the polar head is hydrophilic, and hydrophobic tails, they basically make this lipid bilayer. You know the orientation and the structure of cell membrane. Now, sorry, uh, so most the bilayer selective this bilayer of the cell provide the selective permeability of the molecules. Now, this permeability allows it to control the passage of the molecules into and out of the cell. So some non-polar molecules that are called non-polars. When I say non-polar, just take it, it's like small lipophilic molecules. They can travel easily in and out of the cell, and they can pass through the membranes, while larger and charged molecules require specific transport mechanism. So lipid soluble drugs have better absorption, as I said before. It has better absorption as compared to hydrophilic drugs. The next characteristic that influences drug absorption is size and shape of the molecule. The smaller molecule can cross the lipid membrane easily as compared to the larger ones, because the larger one would require specialized uh, channel proteins to move them from outside of the cell to you know intras extracellular, from extracellular space to the intracellular space. Or it can in case of some larger molecules, um, as we discussed in last lecture, there is a process called endocytosis, where the plasma engulfs um, mm, um, the molecule outside it and forms a vesicle, and it takes a molecule inside the cell. That's called endocytosis. And after the work has been done, it undergoes exocytosis. It just takes some vesicle out and ruptures it, and it the those things, that larger molecules, after the work is done, they can go outside of the cell. Now, another thing, and one of the most important thing, is ionization state of the molecule, which refers to whether the molecule prefers to stay in a state of ionized form or unionized form. This influences the solubility and its permeability. Now, let me explain. So, we have different pH variability throughout our body. Like, our stomach is very acidic, our blood and plasma are more or less neutral, whereas our urine, like the one that is excreted, can be sometimes basic or acidic depending upon condition. But you get the point, right? There is variability in pH condition throughout our body. Now, this influences you know the drug. Some drugs are lipid soluble as function of pH of their surrounding. Let me explain. Ionization state of a drug is decided by the pH of its surrounding. Most of the drugs are either weak acid or weak bases, you know so which mean they can be easily charged or uncharged depending upon the pH. Uncharged forms are better absorbed and distributed as compared to um, uncharged are like better absorbed and distributed as compared to charged ones, because once they have charge they become polar, and you know it becomes difficult for the lipid bilayer to pass on the charged particles through it. So you can see here. Mm, let's first discuss this oral route. Once the drug is taken orally, it goes through, our mouth and esophagus to our stomach. Now the stomach has different pH, um, and the main area of the absorption takes place in the small intestine, and then large intestine. Water is absorbed in large intestine. We discussed all this in last class as well. So once it goes there, it goes to liver. After stomach it goes to liver and then to the systemic route. And in case of inhalation, once we inhale the medicine, it goes to the lungs. Now lungs is very vascular, it has smaller um, you know uh, alveoli, like very small high surface area things. You might have read about it. So it's easier for drug to be absorbed there if you want immediate effect. And then intravenous injection, directly injected, 100% absorbed. And then intramuscular injection. This is how all this happens. Now when we talk about absorption, the in last class we discussed passive, facilitated, and active transport. In case of passive transport, the molecules are diffused from high concentration to the low concentration. So the high concentration, without help of any ATP or any external agent, can easily diffuse from high concentration to low concentration. These are the small lipophilic uncharged molecules. It's very easy for them to be absorbed, as we discussed. In case of you know uh, uh, hydrophilic molecules, now not exactly very large molecules, but some molecules that are comparatively um, hydrophilic, they are also diffused via facilitated diffusion. This also does not require ATP. They require specialized chambers like porins or transport membranes and transport proteins. They are also diffused from higher concentration to lower concentration. In case of active transport, uh, what happens is the drug is taken from area of low concentration to the higher concentration against the concentration gradient, that is with the help of ATP. Now this is basically what happens. So this is a much more detailed slide for that. You see, oral administration. Now how this is you know I'll just explain this. I think it's the same slide I wanted. um so yeah, after so yeah, it's okay, I just explained this. I'll explain more about first class metabolism with our metabolism slide. I think that would make more sense. So yeah, let's go to the first question now. Question from this is from your week 6 question, assignment question. This is your week 6 assignment question. Now see, the question was, a drug is 98% bound to plasma protein. Drug B, which competes with drug A for its plasma protein binding site, is administered. 1% of drug A is displaced by the protein by drug B. As a consequence, the free unbound concentration of drug A increases by. So they are talking about, a drug A and drug B. So let's see how we can solve. The data that we are given is there. So this answers has you have already been given the answer, I guess. Let me see, is there any question? No. Okay, you have already been given the answer. Let me show you how we got to that point. So they say 98% of drug A is bound to the plasma protein. That would imply that 2% of drug A is free. Okay, now drug B displaces 1% of drug A. So now you have 2 units from unbound protein to free units, and now 1% of drug B displaces drug A. So that is one more unit is available. Now total you have 3 unbound units. Okay, so increase in in free drug concentration would be new free drug minus old free drug. So now the new, after the displacement, that is after drug B displaced drug A, we got 3 units. So 3 units minus 2 by 2, and because we have to say that in convert it into percentage, we multiply it by 100. So that's how you get 50% increase. Is there any doubt in this question? You everyone understands this question, right? Perfect. uh, if there is any problem, please let me know. um, you can just unmute yourself and let me know. Yes, yes, Kritika. Okay, I'm sorry. Okay, yeah, which one, Kritika? The yeah. So they're asking the concentration of they are asking about the concentration of free drug in the body, like what's the increase of the free drug in the body, right? So 98%, 90, and then they say that 98% of drug A is bound to plasma protein. So when 98% is bound, that means we have 2% that's free. For sake of simplicity, we just take the percentage as, so 98%. So if we have 100 units, so 98% is bound, so we are left with 2 units that are free. Okay, you get that part, right? The next part states that drug B displaces drug A. 1% of drug A is displaced by drug B. Forget about all these things. Just see, 1% of drug A is displaced by the drug B. So we see drug B displays 1% of drug A. That means we have one more free unit of drug A, right? Because drug B is replacing 1% of drug B. Drug B is displacing 1% of drug A. So now total free drug units is 3. So when we try to calculate the uh, change in any concentration or change in anything, what we do is final minus initial by initial, right? Whatever the quantity. So the final concentration of drug, we are taking the free drug. So we have 3 units of free drug now. So that would be 3. And from the question, we know that 98% was bound. So the um, old free drug unit would be 2, right? So 3 minus 2 divided by 2. So it's 1 by 2. And because we want to convert it into like percentage, we multiply it by 100. So we know that the increase is 50%. Does that make sense? Earlier, so earlier it was just 2 free drug unit, and now you have 3 free drug unit. So that the increase in free drug unit is half of what it was earlier. That is like 75. It became 75%. Earlier it was just 50%. So the increase would be from 50%. Do you understand it? Is this clear now? Yeah, thank you. It's okay, thank you. Okay, now let's go to the second question. So if you're talking about the free and bound state, let's discuss one more topic. It's bioavailability. So bioavailability is the fraction, it's denoted by F. It's the fraction of administered drug, dose of drug, that reaches the systemic circulation. Uh, we just take it relative to the intravenous. I'll just write intravenous. Intraventricular. Sorry. IV injection. So what actually happens is, like, you know I think there was one more question. No, I think it's in next. Let me check. Sorry. Yeah, it's in next to next assignment, I guess. Yeah, not in this assignment. So bioavailability is the fraction of the drug that reaches circulate our systemic circulation. So suppose you're given 100 mg of a drug, and the amount of drug that reaches the systemic circulation is, say, 50%. So the bioavailability of the drug is just 50%. So 100 mg, 50% of 100 mg is 50 mg. So the drug is only 50% bioavailable, and you know and that's how we quantify bioavailability. This is for in case you're given, this was for a numerical question that, forget about it. This I'll discuss this in the next assignment. I'm sorry, I should not have started it now. So yeah, let's move on to the next question. um, Ibuprofen, it's shown in the figure, is a weak acid. In stomach, it will be present in which of the given form? So they have given four options. Ionized form mostly, second is non-ionized form mostly, third is half ionized and half non-ionized, and the fourth is it will form aggregate. Now, does anyone want to answer this question? So we discussed uh, that most of the drugs are either weak acid or weak bases. So depending on the pH, they can be ionized or unionized. So the key thing here is they have mentioned that it's a weak acid. Yes, we can see it's a weak acid. You can see it only has this, like, this interesting functionality. This is aromatic, and all other parts are obviously hydrophobic. This is the only interesting functionality that I can see here. So in stomach, where the pH is acidic, do you think acidic pH would do anything to the as this moiety of the ibuprofen? So, oh god, I'm sorry. So the correct answer for this would be, it's not ionized, non-ionized form mostly. It does not ionize the ibuprofen or anything. Let's go to the next question. Which of the following equations, um, which of the following equation is correctly states the Henderson-Hasselbalch equation for weak bases? You can see all the options here. So there's an equation that we have. Um, it's known as Henderson-Hasselbalch equation. It is used to calculate if the drug is more or less absorbed or distributed in different environments. So it correlates the pH and pKa along and the ionized and ionized concentration of weak acid and weak bases. You know, if the drug is weak acid, then we'll say A minus by AH, where A minus is the ionized form of the drug and AH is an ionized form of the drug. So just look at the option. Which one do you think is the correct option here? I think I should connect this. Sorry. Yeah. So just let me share my iPad here. Can you guys see my screen? Um, I'm sorry. Can you see my iPad? My handwritten note. Is it visible? Okay. So I'll try to explain this from here. I'm so sorry for the mess. I don't know how to. I'll just pin it. Wait. Please don't mind my bad handwriting. It's so I'm just trying to. So so for Hasselbalch, um, this equation. Let me see. What was the question again? Which of the following equations is correct for Henderson-Hasselbalch equation for weak bases? So let's discuss the formulation here. So for weak acid, and obviously for weak base, the pH is equal to pKa plus log A minus and log AH, where pH here is for pH of the environment and pKa is drug dissociation constant. Pa is ionized form of acid, because you can see here this is a weak acid. Aspirin, once it's charged, when it's deprotonated, this carboxylic acid moiety here Let me change the color of the pen. This acid, it it gets ionized to O minus. So it carboxylic acid becomes carboxylate, and this is the charge. So this is A minus here, and this is AH, the protonated part. This is absorbed more easily, and again, this this being the charged part does not get absorbed easily. So when we are discussing this equation for weak acid, the pH will be equal to pKa plus log of A minus, which is ionized form, by AH. For weak base, pH is equal to pKa plus log of B, which is the weak base, and the ionized form of the base. You can see in case of morphine, again, for the sake of simplicity, I'll just denote it as N, and the ionized form has positive charge, like N plus. It's protonated because it has H, so it becomes N plus. Don't mind my note taking ability. Please don't take so notes, so badly. You should have a better handwriting and more organized note taking skills than this. So yeah, now the pH for weak base is pH is equal to pKa plus log of B by BH plus. This is the ionized form. Okay, now I'll stop sharing. So the correct answer is log of pH plus log of unionized drug concentration, that is B, by ionized drug concentration, that would be BH plus. Is that clear? If you have any doubt, please ask me now. I might not have been able to explain it clearly. Is it okay? Should I move ahead or should I explain it once again? I'll take that as a yes and I'll move ahead. Yes, yes. Sorry? Yeah, okay, yeah, sure. Sorry. So I'll share my notes again if you don't mind. So we know that morphine is a weak base. Okay, so morphine, when it's ionized, it gets protonated to NH plus. It becomes NH plus. So Henderson-Hasselbalch equation for weak bases, it's pH. Um, it's an equation that basically uh, it basically states a relation between pKa, that is and a drug dissociation constant. pH is the acidity of the environment, and the ratio of ratio of the ionized and unionized concentration of the drug. In case of acid, it's pKa plus log of uh, ionized by unionized part. Okay, A minus by AH. But in case of a weak base, it is unionized by ionized. Saw this? Because you see, this is the left part. Uncharged part for acid, it's AH and A minus. We know that the thing that lies in the reactant side, we write it first, and then that we divide it by the one that we have in the reactant side. The product goes up and the reactant goes down. That's why A minus it comes up, and which is the, in case of weak acid, say in case of aspirin, the ionized form comes before, and then comes the unionized form, that is AH, the protonated form. In case of weak base, it's just the opposite, because at first it is the unionized form and divided by the ionized form. Is that clear, or did I just confuse you even more? Thank you. Okay, so I'll move to the next question. So, which of the following statement is false regarding the blood-brain barrier? This is an interesting question, and I'll discuss blood-brain barrier briefly. So, sorry. The first option is, the walls of the capillary supplying the brain have tight fitting cells, making it difficult for polar drugs to leave the capillaries. The capillaries in the brain have a fatty coating, making it more difficult for drug to enter the brain. The third is, the wall of the capillaries supplying the brain are made up of several layers of cell which act as barrier to release the drug. And the fourth one is, hydrophobic drug pass through blood-brain barrier more easily than hydrophilic drugs. It's asking which of the following statement is false. Now, let's briefly discuss what blood-brain barrier actually is. So you see here is a beautiful figure of blood-brain barrier. So it's a physical barrier that prevents any random solutes in the circulating blood from entering the brain. You see here, these are neurons and microglial cells. That's not important. The important part here is this astrocyte. You can see the extensions of the cell. This is astrocyte, followed by astrocyte, it's pericyte. And you see this, this red colored part, it's endothelial cell. And this part here, these are called tight junctions. These are made up of endothelial cells. These junctions are important because they give this thing, the selectivity of what can enter and what cannot. And this is the blood capillary. It's so this is basically a cross section of blood brain barrier. You can see it's a physical barrier, made up of astrocyte cell and pericyte cell. It has lipophilic coating around it that basically covers the lumina, basically covers the blood vessels, and this part makes it harder for different floating parts or different floating things in the blood. So blood has several things like solutes, ions, drugs, foreign agents, whatever not. So this covering, like layers of cells, the covering of the cells make it difficult for um, unwanted things to enter the blood. So that's called blood brain barrier. Now, it restricts pathogens, harmful metabolites, and large hydrophilic molecules. See, large hydrophobic molecules, hydrophilic molecules. Hydrophobic molecules can still enter, but not very large actually, because again, it's tightly bound thing, except for the junctions that you see, different junctions. These are like the tight junctions. These are important. Now, the cells of the barrier actively transport metabolic products such as glucose. It's very essential for our, brain. So they let glucose they let the glucose be actively transported to the um, blood capillary. It allows diffusion of small gaseous molecules like oxygen, carbon dioxide, and hormones, and small non-polar molecules to diffuse again, and it restricts passage of peripheral immune factors like signaling molecules, antibodies, and immune cells like cytokines. And it protects our brain from harmful immune activities. So it's very important because brain is very sensitive, and we don't want any kind of things to pass easily to our brain. There are several neurodegenerative disorders, like in case of epilepsy, and where these junctions become leaky, and hence they have this neurodegenerative disorders. But we're just talking about blood-brain barrier at this point. We'll discuss this in much more details in the upcoming lessons. But yeah, at this point, I'll mention something interesting about tight junction. It's made up of basically two main proteins, occludin and claudin, along with junction associated molecules. They don't even allow like small molecules to pass through it, so they are like tightly bound, and they're very selective in letting things come inside the blood capillary. The difference between blood brain barrier and blood CSF barrier is the blood brain barrier has endothelial cells in their tight junction, and in blood CSF barrier they have tight junctions made in epithelial cell, not endothelial cells. This is the only difference. The function there is same. It has to blood brain barrier protects our brain, and blood it protects our cerebral fluid. So the correct answer for that question is the walls of capillaries supplying the brain are made up of several cell layers which act as barrier for release of drugs. Now let's move on to the next question. What are the basic process pathway involved in pharmacokinetics? We have different form of this question in almost all the assignment questions. So yeah, anyone would like to answer this question here? Yeah, take your time. Yeah, perfect. Yeah, that's the correct answer. Option B: absorption, distribution, metabolism, and excretion. Absorption after administration, how the body absorbs it, and the drug goes into the circulatory system, systemic circulation, and then distribution, how in the after once going into circulatory system it reaches various tissues and organs and its site of action. Once it reaches its target, it is metabolized. It's broken down into smaller pieces and like different metabolites, primary metabolites, secondary metabolites, and whatnot. And once that is done, it's excreted via urine or in feces. Next question: what does the term biological half life mean? A. It is the time required to reduce half of the radioactivity level inside the body. Number two, it is the time required for the concentration of a drug to reduce by 50% during the terminal phase. 3. It is the time required by a drug to exactly reduce its original concentration to half as a result of biological elimination. And number 4, it is the time required by a drug in a plasma to reduce half of its concentration due to biological elimination. The correct answer is obviously it is the time required by a drug to exactly reduce its original half of its original concentration as a result of biological elimination. Now, this follows first order kinetics. That's why they gave you the first option. It is the time required to reduce half of the radioactivity levels inside the body. Do not confuse it with the formula because, yeah, radioactivity is first order kinetics. That's why we use the formula. So don't confuse it with that. So, see in this question, I'll zoom it. I'm sorry. Yeah, you can see here. Um, so we are talking about elimination. So this is number of half-life. Do not confuse it with time. So one means one half-life, two means two half-life. Okay. So one half-life, that is the concentration of the drug becomes half in the half of the original dose. So you see the concentration. This is the concentration of the drug. This is two parts combined together. So once the drug enters our body, it increases like this. After one half life, it increases to half of its percent, and then it's the increasing curve. So you don't have to see this when we are talking about biological half life. We generally talk about reduction in the concentration. So forget about this half. um, how do I wait? I'll block this. Yeah. So see, the concentration, this is the first half life. The concentration of the drug decreases by half after the first half life. Okay. After the second half life, whatever is remaining in the blood, so suppose you were given 100 mg of the drug, the dose of the drug, so the dose was 100 mg, you were given that. After half life, the body, you're left with only 50% of the drug, that is 50 mg. Now after one half life, you have 50 mg. After the next half life, you have remaining 50 mg. The half of the remaining 50 mg is 25%, right? So after next half life, you'll be left with 25% of the drug. So that's how half life, the concept of half life works. With each half life, proportionally less drug is eliminated. Earlier, after one half life, 50% of the drug was removed. After second half life, it was 25%. And after the third half life, 20 half of 25%, that is 12.5, will be eliminated. So that's how it works. Okay, I'll remove this. So we can um, inverse the concept as well. You know, once a drug gets into a body, after, so once you calculate it, you know the time it takes to reach the 100% of its implied action, and how half life eliminates like 50% of the drug after each half life, that the half life remain constant. It always remains constant. Okay, don't get confused when they talk about change in time. The half life remains constant. So the formula is T half is equal to 0.693 into VD, that is volume of distribution, and CL is clearance, volume of distribution with increase. So if the amount of drug that is more, if the VD is high, that means the drug is more distributed. So, you know, that increases the half life. And if the clearance is more, like, that would decrease the half life of the drug. Okay, is that clear? right. Perfect. And move on to the next question. Which are following are the phase one reactions except, so phase one reaction, they're talking about metabolism. The options are oxidative reactions, two hydrolytic reaction, three reductive reaction, and four sulfide reaction. So we discussed different phases of metabolism in our last class. You know, metabolism has two phases, phase one and phase two. Let's discuss this. So, uh, metabolism has like two phases, phase one and phase two. Phase one generally involves introduction of polar groups like OH and amine groups, and it's generally to increase the water solubility. The reactions that take place in phase one is oxidation, reduction, and hydrolysis. When phase two, they generally try to conjugate different functionalities, uh, like sulfonation, try to methylation, acylation, to enhance the solubility of water solubility of the metabolites. Sometimes drug goes phase two before it undergoes phase one, and sometimes only phase one occurs, and sometimes only phase two. So it's not not in order, like does not they can be exclusive of each other, or they can happen like in for phase one or phase two. So it does not have to be inclusive and in same order. Okay, so phase one reactions are oxidation, reduction, and hydrolysis to increase water solubility, and phase two is conjugation reactions, where they add sulfate groups called sulfonation. They add glucuronic acid, glucuration, and amino acids, acetylation, and everything. So that's phase two reactions. So among this option, fourth option is the one that is from phase two. So the correct answer is sulfide reaction. Let's move on to the next question. Which of the following one is one of the rules in Lipinski rule of five? Hmm. Number one, molecular weight equal to 500. When they say 500, it's 500 Dalton. Number two, no more than 5 hydrogen bond acceptor group. Three, no more than 10 hydrogen bond donor group. And number four, a calculated log p value less than plus 5. Uh, would anyone like to answer this question? Yeah, that's the correct answer. I calculated log p value less than 5. So Lipinski, the rule of five was given by Christopher A. Lipinski to predict if a chemical compound is likely to be bioavailable orally. So it has four rules, four guidelines. So no more than 5 hydrogen bond donors. So the total number of nitrogen hydrogen bond or oxygen hydrogen bond should not be more than 5. No more than 10 hydrogen bond acceptors. Again, all nitrogen and hydrogen atoms, they have this tendency of accepting hydrogen, so it should not be more than 10. So the hydrogen bond acceptors should not be more than 10. The molecular mass of the drug should be less than 500 Dalton. So again, based on the same concept that it is easier for uh, a smaller lipophilic drug to be absorbed. And the fourth one is log p. Log p is basically octanol water partition coefficient. It should not exceed 5. That means, it's basically um, to quantify the lipophilicity of the uh, the drug molecule. So it should have some lipophilicity like hydrophobicity, you know in order to be orally bioavailable. They generally, because it's all in order of 5, they say it's rule of 5. Now this is one thing: rotable bond should be less than 10. This has been added later. This was not in the original Lipinski guidelines, but it more like amendment. So just to make it 5. Yes, it's important to note that it's not absolute. There are many drugs that defy this rule of 5. This was given just as guidelines, not a hard, fast rule. So, yeah. So, now let's go to the next question. Which of the following routes of administration do not bypass the first pass metabolism? A. Uh, Option 1, intravenous. 2, a nasogastric tube. 3, sublingual. And 4, topical. Anyone interested in answering this question? Anyone? So the correct answer is nasogastric tube. Now, uh, let's discuss first pass effect. Um, First pass effect is basically how the drug gets metabolized before reaching the systemic circulation. So once a drug is taken orally or by nasogastric tube, obviously, so it goes through um, various different like lumens of gastrointestinal tract and the wall of it, and then portal vein, hepatic system. It goes through liver where the major metabolism takes place, and it gets broken into various pieces, so various smaller parts. That's called first pass effect. So the first pass effect does not apply to all the different routes of administration where the things are directly injected or directly given to the in the systemic circulation, like in case of intravenous injection. Because the injection is directly given into the circulatory system, it bypasses the first pass effect. But once the drug gets into stomach and then your liver, the first pass effect takes place in liver. And if that falls in route of the drug or administration of drug, where the drug goes through different passes and has to reach liver, it undergoes first pass effect before reaching its target site. So you can see here, in case of intravenous injection, it goes directly to the systemic circulation. In case of oral administration, it goes to stomach and then goes to the liver, where it has to undergo first pass effect, and then it gets to the systemic circulation and target site. And once it is metabolized, half it can be eliminated by kidney. And so less of the drug is available for reaction, for its action in the target site. Is that clear? Yeah. So there are different factors influencing absorption at the gut area. that is gastric emptying, GI blood flow, stomach pH, and different interactions. So, yeah, and also age. These factors are influenced by age and, you know, metabolism. And people who already have gastrointestinal problems, so it's difficult for them to absorb things as efficiently as healthy people. And yeah, obviously, age also plays an important role in there. So, the next question: what is meant by the term drug metabolism? One, the therapeutic effect of a drug on an illness. Number two, the use of drug not authorized by the FDA. Three, the chemical alteration of a drug by the body. Or four, the elimination of a drug in urine or feces. Yeah, perfect. That's the correct answer because, you know, that's what we read in pharmacokinetics. What happens once the drug enters the things the body does to the drug once it enters the body. So, chemical alteration of a drug by the body. That's the definition of drug metabolism. Very good. Next question. Which of the following explains why newborns and older people often need smaller doses of drug than older children and younger adults? A. They have decreased activities of their metabolic enzymes. Number two, they have increased activity of their metabolic enzymes. 3. Their bodies produce the wrong enzymes. 4. Both age groups have increased sensitivity to drugs. Yeah, yeah, correct. So, newborns and older people, they have very poor metabolism. That's because, you know, their metabolic enzymes, they do not work as effectively as they do in like um, older child. That means teens, in adolescent, and younger adults, like, you know, people in their 20s, 30s, and 40s, unless they reach like after 50, I say, they start deteriorating. The enzymes are not as efficient. So they have people have to like change the dosage of the drugs because just so some let's discuss the concept of bioavailability. Just think, you take a medicine, it goes to your body, and, you know, then it's kind of circulation. It goes to the stomach and then liver, and it's like the liver just throws it, like, you know, like it kind of jumbles it, gets goes to the system, comes back, and, you know, goes to the liver, and then it's excreted. But that's only half of it excreted. And then that's how we determine, right, clearance, volume distribution, half life of drug. There are so many factors that account for drug dosage. So all these factors like clearance of the drug, that's affected with age. And there, so yeah, that's how we need to change the dosage of older people. And we have to be very considerate with how the medicines are given to them. And yeah, there are certain medicines that work much better with food in your stomach. So you're told to take the medicine after having your meal. And there are certain medication where you're asked to take the medicine empty stomach. I'm not talking about this question in particular, I'm just mentioning something interesting. So some some drugs, you know, the absorption of some drugs are increased by certain foods that we have, like, you know, in this case of um, uh, bioavailability and first pass effect. So in case of metabolism, basically. So yeah, there are so many things affecting the dosage of the medicine that we take. Sorry. The next question is, in the intra-articular route of drug administration, injection is given into 1. Arteries, number 2. Atria, 3. Joints, and number 4. Areolar tissue. Perfect. That's a correct answer. In an intra-articular injection or joint injection directly involves injecting medication into spaces between the joints to treat inflammation, and is commonly used for condition like osteoarthritis or rheumatoid arthritis. Perfect. So yeah, that's for the route of drug administration. So in your assignment and your 8-week assignment, there are few terms that you might not be very familiar with. uh, One is Me Too drugs. So I'm discussing this briefly so that when you go through the assignment, you'll have idea of what they're talking about. So Me Too drugs are, medications that are similar to existing drugs. They often have very minor modification that make them more effective, or sometimes they decrease the side effect. So there's already one medicine that exists in the market. They just more or less modify mm, the existing drug very, the modification is very little, so it's like almost the same drug, but the modification is in such a way that they have the same uh, mm, mode of action and activity and everything, but they might have like better, you know uh, better effect, and have like less side effects or have improved activity. So these are called Me Too drugs. They have like therapeutic advantages like improved target specificity, reduced risk of off target adverse reaction, and increased chance to benefit in some patient. So they are called Me Too drugs. And now orphan drugs. Orphan drugs are the pharmaceutical agents developed to treat rare diseases, that affect very small section of a population, but they're called orphan because the main target of a pharmaceutical company is to make profit. They are not NGOs or anything. So every time they put a drug in the market, they want to get some benefit out of it, and they just don't do that for the sake of humanity or anything. So without help of any agency like government agency providing them any initiative or anything, or maybe R&D purpose, they don't make much benefit out of it. So that's why they are called orphan drugs, because companies are not interested in just doing things for the sake of goodness of humanity. They want to make profit out of it, and because it affects only a small section of population, they don't get profit out of it. Okay, so because they are rare diseases, but we still have people working on it, R&D and many things, because they can be breakthrough drugs. And in countries like here in Australia and in US, the government incentivize companies to make this kind of drugs, and that's a very good thing. Yeah. So does anyone have any question regarding um, you know the topics that we discussed today? I Yes. Blood brain barrier. Yeah, okay, sure. Yeah. So you know s- we have blood vessels throughout our body, and the main work of this blood vessel is to transport different gases and nutrients throughout the body, and different organs and tissues that require nutrients and blood. So basically, anything that travels throughout the body is via circulatory system, and we have the same in our brain as well. But brain is very sensitive. We don't want any everything to go to our brain, right? Because it has very complicated way of working and everything. So the body has its own mechanism of protecting our brain. What it does, it has like specialized um, you know um, barrier around the blood vessels in our um brain. So they are composed of astrocyte, you can see here, pericyte, and this blood capillary is lined by endothelial cells. Now, endothelial cells have this tight junctions here. These let selective passage of molecules throughout it. They let very very selective small drugs come cross the blood brain barrier. Most of the time they don't allow, like it's very difficult to make to design a drug that can cross blood brain barrier. It's a good thing as well, because we don't want uh, you know things to go up to our brain. इतना easy नहीं हो, I mean, it should not be that easy to cross the brain and affect it. So that's why it's a good thing. But also, this blood brain barrier makes it very difficult for us to design medicine that can cross this barrier and you know um, and reach the blood capillary in our brain. So, small molecules like oxygen, carbon dioxide, and some of the hormones and non-polar small molecules can cross these barriers, but most of the larger molecules and polar charged molecules cannot cross this barrier because they are tightly bound. What is it that you wanted me to explain? Kuch, was there anything else you wanted to ask me about this? Okay, okay. Yeah. Uh, is it okay now, or should I? Perfect. Yeah, perfect. Um, is there so um is there anyone else who would like me to explain any other thing? Any other question? So I've been meaning to ask you guys. Would you like me to add more numerical questions, or we can do one more thing. If you have any question that apart from the assignment questions, you might be solving any other question, you can just mail me those questions, or maybe just mm, share the question with me in the chat box. We can discuss it in the next session. I mean, if I cannot solve that question in the session that I'm taking at that point, I'll make a note of the question and try to discuss that question later. If you want to add any kind of question or anything at all that's related to the topic, um, and maybe past topics or anything, you can ask me any question. Put the question in the chat box, or maybe just unmute yourself and ask the question. It would be easier if you just type the question in the chat box so that I can take the take note of it and discuss it. So I'll stop sharing now. So if no one has any question, then I'd like to conclude this problem solving session here. Thank you guys for joining, and I hope to see you in next session. And yes, if you have any question at all, please try to bring your question, share your question with me, and we can discuss it. You can discuss it in the forum, or maybe if you don't want to discuss it with me, you can discuss it with any of the tutors. So Yeah, feel free to ask any question. So, okay. Is there anyone who would like to ask any? Sorry. Oh, yeah. Okay. Yeah, yeah, sure. I'll just write it here. It'll be easier for. So, I'm just pinning this message. This is my email ID. You can personally ask me any question, and you can email ask me anything here. This is my email ID. Okay, okay, then I'll conclude this problem solving session here. Bye, guys. Good night. Yeah, you're welcome.